Hello and welcome to the topic Malignant Pericardial Effusion and Cardiac Tamponade in the module Haematology. By the end of this topic, you should be able to define malignant pericardial effusion and cardiac tamponade, explain the pathophysiology of these two conditions, outline the causes and classification of malignant pericardial effusion and cardiac tamponade, describe the clinical manifestations, outline the investigations done, discuss the principles of management, and finally discuss the complications and prognoses of malignant pericardial effusion and cardiac tamponade. Let's get started. First, let's look at the definition of these terms. Pericardial effusion is the accumulation of fluid that exceeds physiological amount, that is a maximum of 50 ml in the pericardial space between the parietal and the visceral pericardium. Cardiac tamponade refers to the elevated intrapericardial pressure resulting from a pericardial effusion compressing the heart. Physiologically, the pericardial space contains about 15 to 50 ml of fluid, and this facilitates lubrication between layers of the pericardium. Pericardial fluid is thought to originate from the visceral pericardium and is an ultrafiltrate of plasma. Here, total protein levels are low, but the concentration of albumin is high. Both the pericardium and pericardial fluid contribute to normal cardiac function. The parietal pericardium contributes to the pressure in the right atrium and right ventricle, essentially responsible for resting diastolic pressure. They also enable even distribution of force across the heart, which allows uniform contraction of the myocardium. Normally, the pericardium can stretch to accommodate small amounts of fluid without significant change in intrapericardial pressure. Though once pericardial reserve volume is exceeded, the pressure volume curve becomes steep. This means that pressure will rapidly increase as fluid collects and ultimately limits cardiac filling. When volume increases slowly, there is a slight increase in pericardial compliance that is able to lessen the steep increase in intrapericardial pressure. The pericardium also plays a crucial role in cardiac changes during inspiration. So during inspiration, the right atrium and right ventricle fill up, and the pericardium limits the ability of the left chamber to dilate. The bowing of the atrial and the ventricular septum to the left reduces ventricular filling volume and hence leads to a fall in cardiac output. Besides that, the pericardium also plays a significant role in hypervolemic states by limiting acute cardiac cavitatory dilatation. Moving on to the pathophysiology of malignant pericardial effusion and cardiac tamponade, neoplastic disease can involve the pericardium through various mechanisms. First, there could be a direct tumor extension from the mediastinal structures or cardiac chambers. It could be neoplastic cells that are capable of hematogenous spread and lymphangitic spread. Additionally, pericardial involvement could be a result of mediastinal lymphatic drainage obstruction. Occasionally, the first manifestation of malignancy is a pericardial effusion. Other times, effusions may be associated with anti-neoplastic therapies such as anthracycline, cyclophosphamide, cytarabine, and all-trans-retinoic acid or ATRA. When pericardial fluid collection occurs, it causes pressure increase in the pericardial space. The result is compression of the heart, especially the right ventricle, causing interventricular septum shift towards the left chamber. This then causes a decrease in ventricular diastolic filling, which leads to a decrease in stroke volume and venous congestion. In the end, there is decreased cardiac output and equal and diastolic pressure in all four chambers. The underlying process of development of cardiac tamponade is marked reduction of diastolic filling when transmural pressures are insufficient to overcome the intrapericardial pressure. The initial response to these changes in an attempt to maintain cardiac output in tachycardia. Systemic venous return is also altered throughout the cardiac cycle. The heart is compressed due to raised intrapericardial pressure, causing impaired venous return. The right atria and the right ventricle collapses due to blood accumulation in the vast and compliant pulmonary vascular bed. The blood collects in the venous circulation at the expense of left ventricular filling, ultimately leading to reduced cardiac output and reduced venous return. So here the focus is on malignant pericardial effusion and cardiac tamponade. The most common cause of pericardial effusion is malignancy, which accounts for 25 to 32% of all cases. Malignant effusions are often a common and serious manifestation of cancer. The majority of malignant pericardial effusion caused by solid tumors, namely lung cancers, breast cancers, hematological malignancies such as lymphoma or leukemia, and malignant melanoma or mesothelioma. Pericardial effusions are classified by their onset, which may be acute, subacute, or chronic, which lasts for more than 3 months, distribution, which may be circumferential or localized, hemodynamic impact, whether or not cardiac tamponade has developed, composition, if the fluid collection is serous, blood, or rarely air or gas, and size, and this can be semi-quantified using echocardiographic assessment. Pericardial effusions are often initially asymptomatic. Other times, presenting symptoms may include shortness of breath, cough, chest pain that is relieved by sitting up and leaning forward, lightheadedness or syncope, palpitations, hoarseness of voice due to compression of recurrent laryngeal nerve, nausea due to the compression of the diaphragm, difficulty swallowing due to the compression of the esophagus, and hiccups due to the compression of the phrenic nerves. Signs of cardiac tamponade are tachycardia, tachypnea or dyspnea, elevated jugular venous pressure, and hepatomegaly, among other common signs. There may be diminished heart sounds and pericardial friction rub, and this is seen in approximately 1/3 of patients. Other signs include vertigo, pallor, dysmorphia, or change in mental status. Hypotension, muffled heart sounds, and jugular venous distension make up the classic back triad of cardiac tamponade. Additionally, a clinician may note pulsus paradoxus, which is an exaggeration of physiological respiratory variation in blood pressure, with a decrease in systolic blood pressure exceeding 10 mm mercury with inspiration. This signals falling cardiac output during inspiration. Kussmaul sign, which is a paradoxical increase in jugular venous distension and pressure during inspiration, may also be noted. In an unstable patient with suspected tamponade, do not delay treatment and with pericardiocentesis for extensive diagnostic workup. This is a medical emergency, so proceed directly with management of cardiac tamponade. Supportive findings of pericardial effusion using POCUS are an anechoic space between the pericardium and epicardium. The volume of fluid is estimated using the distance between the pericardial layers. If the distance is less than 10 mm, it's a small effusion with roughly 300 mL of pericardial fluid. If the distance is between 10 to 20 mm, it's classified as moderate effusion of roughly 500 mL of fluid, and a large effusion measures more than 20 mm and accounts for more than 700 mL of fluid. Hemorrhage or purulent effusion seems echogenic. In stable patients, confirm the diagnosis with echocardiogram, specifically a transthoracic one. That's the gold standard for a diagnosis of pericardial effusion. It can detect small effusion and effusions even exceeding 50 mL of fluid. Findings that are supportive of cardiac tamponade include a predictable order of chamber collapse. In this stage, there will be collapse of the right atrium during systole and right ventricle during early diastole. Later, what follows is the collapse of the left atrium, and this is 98% specific for cardiac tamponade. Rarely, the left ventricle collapses. ECG is indicated in all patients with suspected pericardial effusion to rule out ischemic causes. However, ECG may be normal if the effusion is small. Sometimes, low voltage complexes and electrical alternance, which is the consecutive QRS complexes that alternate in height due to swinging motion of the heart when surrounded by large amounts of pericardial fluid, may be seen. In a cardiac tamponade, there may be sinus tachycardia, low voltage QRS complexes, electrical alternance, and possible pseudo-PEA where myocardial contractions might be observed on an echocardiogram. Other imaging modalities that can be utilized include a chest X-ray, which is really not required to diagnose pericardial effusion but more often to exclude other causes of dyspnea. Further imaging with the transesophageal or CT-MRI. Further imaging with a transesophageal echocardiogram or CT may be indicated if small or lobulated effusions are suspected. Whenever there is a reason to suspect malignancy, pericardiocentesis with cytologic examination should be performed. In hemorrhagic effusion and in cases where there is no history of antecedent trauma, cytologic evaluation is especially important as such effusions are highly likely to be malignant. In the distinguishing between malignant cells and atypical mesothelial cells, as well as providing information regarding the tumor origins, immunohistochemical stainings may be helpful. Do note that a negative cytology does not exclude the diagnosis of a malignancy, particularly if the index of suspicion is high. So a pericardial biopsy can be performed through a subxiphoid or transthoracic pericardiostomy or by a pericardioscopy, which allows direct visualization of the pericardial space. Management in malignancy associated with pericardial effusion or cardiac tamponade is mostly procedural and surgical based. Components of management may include removal of fluid to improve hemodynamic status, prevention of effusion reaccumulating, management of pericardial constriction, and treatment of the underlying malignancy. What is important to note is that pericardial involvement from malignant disease is not curable and treatment is predominantly palliative. Most patients will have a short life expectancy with some exceptions. Now, let's first look at the acute management of effusion. Asymptomatic or minimally symptomatic pericardial effusions can be managed conservatively with careful monitoring and appropriate anti-neoplastic therapy. Development of symptoms such as fatigue, dyspnea, or chest heaviness should prompt repeat echocardiography, and therapeutic intervention should be considered. Highly symptomatic patients or those with evidence of hemodynamic compromise, urgent fluid removal is needed to prevent hemodynamic collapse. Then moving on to prevention of effusion from reaccumulating, although pericardiocentesis effectively relieves symptoms and improves the hemodynamics, fluid can still reaccumulate in as many as 60% of cases. Therefore, management of a proven malignant pericardial effusion should be combined with measures to prevent recurrence. Approaches are prolonged catheter drainage, obliteration of the pericardial space, and the creation of a permanent pericardial window allowing drainage of fluid into the pleural or peritoneal cavity. A prolonged catheter drainage effectively prevents fluid reaccumulation, and drainage may be required for several days. The catheter should not be removed until drainage is less than 20 to 30 mL in 24 hours. Intermittent rather than continuous drainage may help to maintain catheter patency. Constrictive pericarditis may warrant surgical removal of the pericardium, provided that the prognosis from the malignancy justifies surgery. Pericardiectomy may not benefit patients with mild constriction or those patients with very advanced disease. Constriction in patients whose only abnormality is a mild to moderate increase in central venous pressure with little or no edema can be followed up clinically. Patients with end-stage constrictive pericarditis manifest by cachexia, atrial fibrillation, low cardiac output at rest, and depressed serum albumin level due to protein-losing enteropathy. Intrapericardial treatment or chemotherapy can be given if confirmed malignant pericardial effusion has been attempted. Relatively high doses of chemotherapy is administered locally with minimal systemic side effects and palliation of symptoms from a hemodynamically significant effusion. The major complication of pericardial effusions and cardiac tamponade is the development of cardiac arrest. Other complications from treatments such as from prolonged catheter drainage includes pericarditis, chest pain, catheter occlusion, infection, fever, pneumothorax, ventricular puncture, and cardiac arrest. Again, most patients who experience symptomatic malignant pericardial effusion have a short life expectancy, the median being 2 to 4 months. Pericardial effusion accounting for 86% of death from cancer patients with symptomatic effusions remain the primary cause of death in this subset of patients. Good prognostic factors are negative findings of malignant cells in the pericardium, non-solid tumors, and patients who are candidates for systemic therapies or in whom malignancies are well controlled. Bad prognostic factors are the presence of malignant cells in the pericardium and in cases with solid tumors such as breast and lung carcinomas. To summarize, pericardial effusion is the accumulation of excess fluid in the pericardial space. What follows is cardiac tamponade, where there's elevated intrapericardial pressure causing compression of the heart. Pericardial fluid collection leads to increased intrapericardial pressure and compression of the heart, and this ultimately contributes to a cascade of events that result in decrease in cardiac output. In the context of malignant pericardial effusion, most common causes are solid tumors such as lung and breast cancer. Hematological malignancies, malignant melanoma, and mesothelioma are also possible causes. Malignant involvement of the pericardium can be manifested as pericarditis, pericardial effusion, cardiac tamponade, or pericardial constriction. Important features to look out for are retrosternal chest pain, the Beck's triad in cardiac tamponade. The gold standard investigation remains to be a transthoracic echocardiogram. Components of management include removal of fluid, prevention of reaccumulation of effusion, and managing pericardial constriction as well as treating the underlying malignancy. Try not to delay pericardiocentesis for extensive diagnostic workup in unstable patients with suspected tamponade. We have come to the end of this session. Thank you.